With me is Bruce Wampold. He is a very influential psychotherapy researcher and professor at the University of Wisconsin-Madison. His research on the efficacy of psychotherapy and its underlying mechanisms of change have made a significant impact in the field. And his recent book, The Great Psychotherapy Debate, now in its second edition, reviews the research evidence for what works in psychotherapy. So I'm very pleased to have you. Thank you, Bruce.
Thank you very much for the opportunity. Looking forward to it.
Well, I'd like to start off a little bit with you, and I'd like to ask you, how did your background in mathematics influence you as a psychotherapy researcher?
Well, it's interesting. I was just telling a class I'm teaching that I never took a psychology course as an undergraduate. So I was a math and science major, and that was my interest, and I was a little intimidated by psychology. But I didn't know what I wanted to do. It was the 1970s, and a lot of anti-war protests and things were in turmoil in many ways. So I decided I'd become a high school teacher for a few years to figure out what I wanted to do. So I was a high school mathematics teacher and wrestling coach at Punahou School in Honolulu.
Great.
And the most famous student at the school when I was there was Barack Obama.
Oh, so, really?
I don't take any credit for him. But during that time, I got interested in the students because I had a wide range of students. We had, kind of the richest, we call them haole kids, the white kids from Honolulu, as well as Native Hawaiians and Samoans and Japanese Americans and Chinese Americans and so forth. It was a very diverse group, and I watched the students, some of whom succeeded, overcome many barriers and had this resilience, and others had every opportunity and couldn't thrive. So I got interested in psychology through just my curiosity about these kids. So I went back and became interested both in psychotherapy and psychotherapy research.
Yeah, it's something interesting that comes up also in that answer is that it seems to link well with your interest in multicultural issues in psychotherapy. So immediately there.
Yeah, it does. It does. And, psychotherapy has always, for me, been a way to give life or greater satisfaction or better functioning to people who don't have it. And often it's people who have faced barriers, and we know that various cultural groups, particularly in the United States, have significant barriers to many opportunities. And so it only makes sense. I can't imagine somebody interested in psychotherapy who's not also interested in multicultural, because they really belong together. Yeah. It is the essence of what we do.
Yeah, and when you went into this focused interest in psychology and psychotherapy specifically, was there any author or book that really enamored you with the field?
Well, Jerome Frank's Persuasion and Healing. I go back and I read it periodically, and it's just a fascinating, prescient, small book. And what's interesting is that he was trained as a psychiatrist in the medical model. Yeah. He believed that some treatments were going to be superior to others, and there were mechanisms of change involved in particular treatments. And he changed his mind based on the research evidence. So it's more than just he wrote great stuff. His own attitude towards research evidence and how it should be used is quite inspiring. The other thing that really was influential in my development was the following. So I entered graduate school PhD program in 1977. And, during the decade preceding that, Hans Eysenck's criticism of psychotherapy was pretty much accepted. Psychotherapy is bogus. It doesn't work. It's no better than spontaneous remission. So when I was in my first semester as a graduate student, 𝗔𝗋𝗄𝘅 and 𝗵cie Smith's meta-analysis on psychotherapy effectiveness came out. And that's another article I go back and read because it's absolutely brilliant. It's brilliant methodologically, it's brilliant in its creativity and its curiosity. And so that also gave me hope the stuff really works. And I should talk about this just briefly. But psychotherapy for me in my own personal development has been very important. So it's not just an academic interest entirely. For a number of reasons, I found psychotherapy extremely useful in my own life. So it's a passion on a number of different levels.
So on the emotional, personal, and the academic research side.
Yeah, absolutely.
So you would still recommend to go back and read Persuasion and Healing and the old meta-analysis by...
Well, it is really important for people to go back and read not just the classics, but more obscure things. Because the history is important, both in terms of how we've progressed, but also in terms of what we've ignored. I talk some about this in the first chapter in the new edition of the Great Psychotherapy Debate, but we've left out in the United States, the incorporation of psychotherapy in the healthcare delivery system has been wonderful. Okay, let's not diminish that because psychologists get paid often through managed care or Medicare, Medicaid, through insurance. But not only do they get paid, but it's given access for many people to have psychotherapy. I mean, it was for the fairly well off, in Freud's time, if you want pay for psychoanalysis, that was costly, and usually you paid out of pocket for that. So access has been increased, but the kind of incorporation or assimilation into the medical model has we've sacrificed because of it. We've given up some important things, and I think we need to go back and really pay attention to what we've left out.
Well, bringing what you're talking together, there was this bitter pill that a lot of people still have a hard time swallowing, and that you've written a lot about, which ties within the common factors approach and the contextual model that you present. So I'd like to ask you, it's called sometimes the Dodo Bird verdict. I have to ask you about it. Like, all psychotherapists, at least for particular disorders, seem to have no differences in outcomes.
Well, yes, that's true, but we really have to be careful about how we state it. So it's not any particular treatment is effective. It has to first be given by a skilled therapist who believes in the treatment, and to a patient who also believes that this treatment is a viable means to overcome their difficulties. Okay, so the therapist is really, really important, and we know about therapist effects, and we know that there are some great CBT therapists. When I say great, I mean effective, can actually help patients. There's some great dynamic therapists, there's great humanistic therapists, and so forth. But there are also some very, how should I say it?
Not efficient.
Not efficient. So, we've looked at data. There's some therapists who really struggle to help any of their patients. And that's something that should be concerning. So that's one qualification on the Dodo Bird. The second is, and this is something that I have come to realize more and more. So treatments with a structure seem to be more effective than just open-ended talk therapy without any structure for how the patient is going to overcome their difficulties. And actually, if you go back and you read Jerome Frank, he talks about this. So you have to explain to the patient how what we're going to do in therapy is going to be helpful for overcoming these particular problems.
I believe it was the myth.
Right. So there needs to be a rationale or a myth and a ritual. So something that the patient does. And I'm very clear now about that in my writing, that just meeting with an empathic therapist, don't get me wrong, the evidence is pretty strong that that's helpful, okay? But for the particular difficulties, we need some actions. We need to have the patients do something, enact something that makes sense and will help promote them to do something that's helpful in their lives. You know, we do it in very different ways, but dynamic therapists, CBT therapists, emotion-focused therapists, and even humanistic therapists are pretty clear that the patient, you have to do something to help yourself overcome these difficulties. Now, what we do, they're pretty varied, right? CBT therapist is going to do something completely different. Well, completely different, very different than a CBT therapist. They have commonalities. But one of the important common features is we get the patient to do something that's important in their lives. So they have some agency or some self-efficacy, some mastery. You know, Jerome Frank talked about mastery. His discussion of mastery, by the way, I digress a little bit, is very similar to how Albert Bandura talked about self-efficacy. You read, they're almost identical. So you can read other theorists. Irving Kirsch talks about changing response expectancies. These are all very similar things with some important distinction.
So trying to sum up with what you're saying, these three pathways you're talking about, so it's important in your model, let's call it, and during the research that you've done, so the real relationship, the client's belief in the therapy, and the actions that go with it.
That's right. Yeah. And, you know, some therapies emphasize one of those more than another. And I think it's important for both treatment, people who develop treatments, but also therapists to keep in mind all three pathways. Okay, CBT really emphasizes the last pathway, but they limit effectiveness if they don't also consider the fact that the human relationship is a really healing aspect. I mean, we know this from basic science. Loneliness is a better predictor of mortality than is obesity, diet, exercise. So the human connection for many patients is amazingly healing. Okay. So CBT therapists need to pay attention to that. On the other hand, humanistic therapists put, you know, a lot of eggs into that first pathway, not realizing these other pathways are important too. So I want well-rounded therapy.
It's a different way to espouse an integrative approach. It's maybe not the classical integrativism SEPI members will talk about, but it's trying to bring in these different elements that you find effective.
Well, yeah, I like the way you frame that, because it is an integration. Maybe not the way integration is.
Commonly,
every person in SEPI has a different definition of integration is, but it is an integrative model. You're right.
But tell me something. When we read in the research literature that 5 to 9%, I think, of the variance in outcome is due to the therapist himself, what does this mean? Because for people not very familiar with the research, it could seem like a very small number, 5 to 9%.
Yeah, it's good. When I do workshops or presentations, I have some slides to explain how important this is. And I use American baseball as an example because,
Really?
because the difference between a star player
Uh-huh.
in terms of batting average and a mediocre or even a marginal player is not very great. Okay, but it makes a very important difference. So, Michael Barkham's research in the National Health Service or research that we've done in managed care, the difference between the top quartile of therapists and the bottom quartile in the long run makes a significant and important difference in outcomes.
Yeah.
So, and Zach Immel's done a simulation of this. If you take the patients of the bottom 5% of therapists and just randomly assign them to other therapists, the number of recoveries, additional recoveries, is amazing. So a small difference over the long run is important. So I hope your next question is, well, what does that mean for policy? Are we supposed to get rid of the bottom 5% of therapists? What should we do? So, my career now, and I'm getting towards the end of it, is devoted to how do we help therapists become more effective. We just did a study. The therapists do not improve over the course of their careers. Some do, but on average they don't. In fact, they get a little bit worse. We have to do something about that. And I think we know what to do. We need to do continual improvement. People need to practice their therapy skills over the lifetime.
Deliberate practice.
So, some form of deliberate practice.
So let's jump right into that. Of course, I would like to ask you about that. So knowing that probably therapists, this is, by the way, this is a very scary thought also, the bitter pill to swallow, another one. The idea that someone could spend their life in training and supervision and going to seminars and their outcomes don't get better. So this
I don't think it's a bitter pill at all. I think it's pretty understandable. Psychotherapy is a very unusual profession. Okay, what other profession is so isolated and secretive, right? We go into a room with a patient. What's done there is confidential. Nobody really knows, okay? We don't get any feedback really about outcomes or our technique. Surgeons, they know whether they have goofed because the blood vessel ruptures or something. Okay, lawyers do their work in court or it's examined. It's really hard in psychotherapy to get better. So I don't think it's the fault of psychotherapists or the fault of the profession. It's just structurally a very difficult thing to do. So we really need to build in ways to not just get supervision through our lifetime career of practice, but build in opportunities to practice particular skills. We know musicians practice, right? They asked Pablo Casals, the famous cellist, he's in his 80s, right? Why do you practice 4 or 5 hours a day? You're the best in the world. And you know what he said?
That he feels he's still getting better.
That's right. That's exactly right. So, and it's practice outside of performance. Okay, so we do psychotherapy 6 hours a day. That doesn't count. You need to really have focused practice with feedback and a coach outside of practice. But you're right. This is a change, a big change in the way we do business. So, and it's hard to ask therapists to do this. They're busy. This is not work that's going to be compensated or paid for. Although I think employers and payers should insist that people do this. In the United States, we have continuing education. Many other places do this. You go to a seminar and you sit there. Oh, it's kind of interesting. Maybe it's boring. Oh, I could use a little of that. Why, instead of sitting for 8 hours listening to somebody that talk about something. We can't spend that 8 hours practicing with feedback. It'd be much better spent.
Before jumping to the routine outcome monitoring, the feedback, I'd like just to make a bridge there. Could you tell us a little bit about, well, they have been called the super shrinks sometimes, but just to talk in general about, let's talk the top performers, or what do you think are the most efficient therapists? What do you think are the defining qualities of these people?
Yeah. Well, first of all, I don't like the term super shrinks. Okay. The distribution of outcomes of patients is pretty well normally distributed. There are some people who are clearly more effective than others, but maybe they're all stars or super shrinks or something. But we can all get better. Okay. So I don't like to think of, well, there are these people way out here,
on the pedestal.
And if we're not there, then we're nothing. I really don't like that. But we are starting to identify what are the characteristics and actions of effective therapists. Okay, so I'll just go through them quickly, and this is due to some studies on the Alliance, some of which I've involved in. Some of the work is from Tim Anderson and his facilitative interpersonal skills, and there's other research coming out that seems to validate this. But the more effective therapists are able to form a strong collaborative working alliance with a range of patients. So even with the difficult, interpersonally aggressive, challenging, maybe borderline features, now we know we're not going to have a strong alliance or as strong alliances with other patients, but the good therapists, effective therapists, can form at least a decent working alliance with those difficult patients. So that's one thing. The facilitative interpersonal skills, again, shows up most conspicuously with the challenging patients, but verbally fluent. So more effective therapists are able to verbalize succinctly and articulately what they want to say in a very precise way. So if you listen to good therapists, they're doing interpretations or they're explaining a cognitive therapy or whatever they're doing. It's clear. It's understandable. Good therapists are able to read the affective state of their patients, even if the patient's trying to hide it or cover it up in some way. So I got some great video clips of therapists who recognize sadness in a patient, even though the patient's smiling and joking. So they can tell they're covering up or avoiding the sadness, and they understand this. Good therapists are able to modulate their own affective reaction. Okay, sometimes you want to activate the patient and show activation and strong emotion. Other times, therapists have to cover up their affective reaction to a patient. Okay, I've had a student who worked with a patient who didn't bathe. It was disgusting, and we had to work on how do you cover up your disgust. Because you don't want to communicate to the patient that you're disgusted. Patients with anxiety disorders, particularly, ones that might have a panic attack in a session. I had one of my trainees whose patient actually vomited in a session because they were so anxious. So you have to show calmness even though you're anxious. What's going to happen in this session with this highly volatile patient? Well, I'm calm. So affective modulation. Some of these are not surprising.
They all make sense.
Warmth, empathy, understanding. Excuse me, and communicating that to the patient. Okay, one that seems like it's obvious, but is a struggle for some patients is focus on the patient rather than on oneself. Okay, so we talk about introjections or letting countertransference, letting our own issues intrude, and that's something that really effective therapists is a laser focus on the patient and their difficulties and how we're going to overcome those difficulties. So you're communicating all the time that we're here to help you get better. But good therapists, when progress is made, the patient will, and the therapist will help them attribute that to their hard work. So when a patient says, I want to really thank you, what you've done for me, really helpful. The good therapist will turn that around and say, well, do you recognize all the hard work you have done? Yeah. And that's what made this therapy successful. So and these are skills, that CBT therapists use, dynamic therapists use, humanistic therapists use, family therapists use. These are, I guess, common factors, but they're done in slightly different ways. The way a CBT therapist might show understanding and concern could be different than a dynamic therapist. So there's some subtleties how you want to adapt these common factors to your particular therapy orientation.
Yeah, and all the things you're saying, they're all trainable.
Yes.
Yeah.
And we need to practice them.
Yeah.
Okay.
So this is where the deliberate practice comes in. So we can focus on what's not happening in the session and work on that.
Yeah. And we know this from learning any skill.
Yeah.
So I'm a sailor, and when I learned how to sail, and even now, you have to practice over and over again various maneuvers. And so when you go out and sail for recreation, you usually don't practice any of these things. And this is why I like to do some racing in sailing, because you have to practice the particular maneuvers and you do them over and over and over again. And that's how you get better.
And you've also done research, and there's also research of our biases in a way that we don't really know how well the therapy is, the alliances, and a lot of things cannot come to consciousness even for a therapist sometimes. This is where I think the feedback comes in, even the outcome monitoring. So
yes,
I'd like to ask you, so let me play devil's advocate here.
Okay.
Do you
I like that. So
great. So do you think an outcome measure like the OQ45, do you think it's enough for us to know that we're doing good therapy?
And the literature seeming to show this. It looks like when routine outcome monitoring, like the OQ or Scott Miller's ORS, and there's, as you know, several others. When it's helpful for particular patients. Okay, so this particular patient is not getting better. That's useful information for the therapist. Okay, and then the therapist does something differently with that patient. Hopefully, in my mind, the important thing is let's discuss your progress. You're not making progress, and I'm here. Remember the focus on the other. Yeah. I'm here to help you. And so if you're not making progress, we have to think about what to do differently.
Yeah.
But it doesn't look like that kind of feedback helps therapists become better therapists. And in fact, the study I mentioned about therapists over their careers not getting better, that was in a center where they had access to the OQ.
Okay.
So just getting that information, because it's not really actionable information. What should I do differently? Is it my work with the alliance? Do I need to work on verbal fluency? Is it the fact that I get irritated by difficult patients, and my empathic responding is interfered with.
Mhm.
So we need more specific feedback if we're actually going to use the feedback
Mhm.
to become better therapists. So feedback, I think, is really important. I think the outcome monitoring, both for particular clients and to know how we're doing in general.
Yeah.
In general, if we're not helping most of our patients,
Yeah.
then that's motivation to get better.
Uh-huh.
Okay.
Uh-huh.
So, but it's limited. It really is limited in what it tells us about what we're doing as a therapist.
And what about taping of sessions, be it video or audio? How do you think about the possibilities of that for feedback?
Well, I think that's really good if we use a coach to help us.
Okay.
Okay. Again, it's really hard to identify. It's not just therapists. It's just the
Professionals.
Yeah, professionals or people, students in classrooms and things. It's hard to really know how we're progressing
Yeah.
without somebody who's a really effective coach.
Mhm.
Okay, so when I say that, I say it because just because you're the most super shrink, you're a really effective therapist, doesn't mean you're going to be an effective supervisor.
Mhm.
Okay, it's a related but different skill.
Yeah.
So to get better, we need to go through our tapes with somebody who's there to help us improve.
Uh-huh. 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 Well,
And I'm actually working on some ways to do this. I'm working with some kind of tech people to develop electronic means
mhm.
so that therapists can get together and be coaches for each other.
Like an online system?
Yeah. So, because it's really hard for therapists to meet with other therapists because
Sure.
we're at a distance, and so we're trying to get therapists who are similar, working with similar kinds of patients, using similar
Yeah.
treatment strategies and so forth, to get together and go through tapes and
Yeah.
support each other and practice skills.
Yeah. By the way,
Yeah.
do you believe in therapists self-report as something that could be very valuable, or would you like to focus mainly on the tapes and the audio, which is more concrete?
Yeah. Self-report's hard. It's really hard to talk about what we did in a session,
Yeah.
and particularly those things that we're concerned about. So, and it looks like in supervision that there's agreement. You really need the actual therapy interaction
Mhm.
to be most effective in the supervision.
Yeah.
So it's not always possible, and then of course we have to do it from therapist report.
Yeah.
But yeah.
By the way, so we talked about, it came out the second edition of your book, the Psychotherapy Debate, the Great Psychotherapy Debate. Because it's a big one, and it's a wonderful book. And I'd like to ask you, between the first edition, which is 2001, I believe, and this one, if you had to choose one innovation that came between those two editions, what do you think it would be?
Innovation in psychotherapy?
Research,
Well,
yeah.
Well, let me talk about a couple different things.
Go.
I know you only asked for one.
No, go ahead.
So in terms of practice, the routine outcome monitoring is one big innovation. It looks like the actual effect maybe is not as large as we thought it was. There's a new Cochrane review that is pretty clear that the effect is smaller than we had previously thought. But what it's done is, so importantly, is to focus our attention on outcomes.
Yeah.
The goal is to help patients. And this idea of measuring outcomes has really influenced how most of the field now thinks about psychotherapy.
Yeah.
So when we talk about effective therapists, we're not talking about those that have a good reputation or are nominated by others or give workshops. a expert therapist is one who achieves admirable or commendable outcomes with most of his or her patients. So the focus on outcomes is a big development since 2001.
Yeah.
In terms of understanding psychotherapy, the big development, I think, is the frequent measurement of outcomes and process.
Okay.
The longitudinal over the course of therapy, and the multi-level models where we disaggregate what's within patient variability, between patient variability, within therapists, between therapists. We're starting to understand.
Yeah.
Right. We're understanding now, to a greater extent, how psychotherapy unfolds over time, what causes something to happen in kind of the course of therapy. So the alliance is stronger than it usually is for this particular patient. What happens to symptom levels in the following week? So we can really kind of start to track this. And it's not real time, but it's as close to real time as we're going to get in therapy. And, I started my career looking at utterance by utterance in a particular session. And so that's probably the next place we're going to go.
Okay.
And some people are looking at utterance by utterance at machine level learning. So can you track fluctuations in empathy due to semantic structures within sessions? So we're on the verge of finding out about psychotherapy in ways that we haven't before. I mentioned this at a session at SPR, but I think in 10 years, 95% of what we know about psychotherapy will be new.
Really?
Yeah.
You think we're that close to greater innovations?
I think so. We got great methods coming online and great researchers coming online. And it's my hope. I think we just scratched the surface of real understanding about how people change.
Go ahead.
Yeah. Well, I'm optimistic that we're going to know much more than we know.
And you're not just focused on outcome research. You're talking about being able to do process outcome research to actually know what's working.
We have to do. There is no outcome research
by itself.
And there's no process research. The goal is to link what we do in therapy, and we being the therapist and the patient, because both people are working here, and how that leads to change, which is outcome. So the distinction between process and outcome research will disappear. So hopefully in 5 years, people won't say, I'm a process researcher, I'm an outcome researcher.
Yeah. In your own practice, do you find yourself being more influenced, or do you find yourself gravitating towards any kind of case conceptualization from any model? Do you tend to do that?
Well, I don't do practice anymore because I just don't have the time given my other commitments, but I'm still active in training therapists. For me personally, I like to conceptualize cases from a psychodynamic perspective. I also like to think about problems systemically. So when you get the kind of systemic conceptualizations or way of working from family therapy, I think is important, although the system for me is much more than just the family. It's also the culture, the society, so kind of the rings, Bronfenbrenner's ecological model. But I'm pretty pragmatic in interventions. So I like to really think about interventions as matching the folk psychology of the patient. How does the patient think about his or her difficulties? And what's the cultural way of conceptualizing mental distress.
Yeah.
And then because some clients who are very pragmatic and concrete may respond much better to a cognitive behavioral therapy, whereas others need more affect-focused psychodynamic work. So I'm comfortable working in a variety of different ways.
Yeah.
And Jerome Frank said this: therapists need to learn several different treatment modalities to find the one that fits with the patient. So it's in persuasion and healing.
Again.
So I try to operate pretty pragmatically,
Yeah.
but also always thinking of the humanistic stance that this is somebody who is in extreme amount of distress meeting with another human being, and I have to meet with them as a caring person.
Mm-hmm.
You know, psychotherapy is pretty amazing. What's our contract? No matter what the patient says, how distressing it is, how shameful it is, with some exceptions, we're going to be there again for them next week, not just present, but empathically present.
Yeah.
What a great gift that is.
Uh-huh.
You know, there's no other relationship we have like that.
Uh-huh.
So there's that humanistic aspect that I think we always have to keep in mind when we meet with patients.
I believe you called it also a common factor in a way, the humanistic element of
Yeah.
psychotherapy.
Yeah.
Yeah.
Absolutely, yeah.
I'd like to... Yeah, go ahead.
No, I was going to repeat myself just because I want to emphasize things, but I think I said it. No. Well, what I was going to say is that I think CBT therapists, I'm going to use the extremes here, have to keep that humanistic thing
alive
in mind, because naturally that's something they don't think about.
Yeah.
On the other hand, the humanistic therapists have to keep the pragmatic part. We have to help the patient do something to get better.
Yeah.
So it's as therapists, we always have to keep multiple things in mind, and we have a tendency to kind of gravitate towards what we do well and what we feel comfortable with. But remember, it's the things that doesn't come easy or we don't feel comfortable with that we have to work on.
Practice.
Yeah, that's right.
So I'd like to finish off with a question that I've asked all of your colleagues in these interviews, which is, what advice would you wish to have gotten when you were starting out as a psychotherapist?
That's a great question. Well, it's easy to think about, well, you know, we got to keep an open mind, we got to be willing to change and so forth. But I think what I didn't realize is what a effort it takes to remain curious and learning. Okay, and this applies to my work as a therapist and supervisor, but also to my work as a researcher.
Yeah.
You can never just say, I know enough to do good research. New things are coming online, new methods, new understanding, developments in neuroscience and placebo studies and anthropology. Just the realization that you get your PhD or you're certified as a therapist,
and
and then you've made it. I've made it. I passed my last exam. So I passed the exam to be a diplomat in professional psychology. I've done it. Okay, I'm board certified. No, it's just the first step in a continual process.
Yeah.
And that's a challenging and then formidable, but I wish someone had said that it's also what makes it exciting.
Yeah.
You know, it's kind of boring just to quit.
Yeah.
And be good but not great at something. So
Bruce, thank you so much.
So I guess like Pablo Casals, I said, I'm going to keep practicing.
Exactly. You're still getting better.
Yeah, yeah.
Bruce, thank you so much for the opportunity.
Well, thank you. It's been a great conversation.